We still cannot hear
Or
you.
one of the
Yeah, that's good.
one of the things.
Now it's
One
good.
of I still hear the live case going. So live case is going and interfering with the sound.
Juan, we can hear you in the hall and you're live. We see you on
Yeah,
our
I'm just
screen.
the live case is still going. And,
If you can turn
I'm
off the live case from Dr. Granada so that we can hear him.
exactly. Here we go. Because the live case, exactly. So how you doing? And thank you again for the kind invitation. And it's great to be here with you, even if it's on a virtual way. This is really an unbelievable opportunity to say hello to my friends and to all of you, Adele, Mervat, and all the TCT, Middle East friends. A heartfelt, congratulations for this amazing meeting. And the live case is a great introduction to this talk as I try to summarize what are the most impactful lessons that we have learned this year on structural heart innovation that, as you can see, is perhaps the fastest growing subspecialty in our field. So let's just go straight into what we have learned this year. And let's start with transcatheter aortic valve replacement. I mean, we just saw a case in a very complex anatomy, and we have actually learned significant amount of lessons since the beginning of the specialty. I like to put this timeline because it shows the evolution of this field. And besides stents, I don't think there is a field that has moved so quickly than transcatheter aortic valve replacement. After following the first balloon expanding TAVR experience by Dr. Crivier in 2002, in approximately 20 years, we were able to move the indication of this particular technological approach into pretty much every single patient cohort. And if you look at the timelines of all trials and all risk populations, we went very quickly from inoperable risk patients all the way down to low risk patients in approximately a decade. I really think this is the year in which TAVR established really the performance against surgery. This is one of the examples done by an independent group in a patient-level meta-analysis, pretty much essentially showing that TAVR is equivalent with certain difference than surgery in different population subtypes. And I think it's fair to say that pretty much in every single patient population and risk profile, TAVR is equivalent to cardiac surgery. But there are still some questions that need to be answered. And one of the important questions that was answered at TCT this year is about the relevance of symptoms. All the guidelines essentially tell us that you need to have severe aortic stenosis, which is symptomatic, to be able to trigger an intervention. And in this study, the early TAVR trial that was presented at TCT, the hypothesis of what about if we intervene early patients with asymptomatic aortic stenosis, do the patients do better or do worse? Which is interesting to see is in this study that randomized patients to TAVR or what was called clinical surveillance. You see a significant difference up to 5 years in the patients that were managed and observed clinically compared to the patients that had preemptive TAVR. One thing that I want to clarify is these patients were truly asymptomatic based on a stress test. So these patients really didn't have any symptoms or any hemodynamic symptoms related to the aortic stenosis. So you see the results are significant. If you break down the endpoint, you see that death was very similar, stroke is slightly high in the conservative group, And pretty much all the changes or all the endpoint was driven by unplanned cardiovascular hospitalization, meaning patients becoming more symptomatic as time went by. As you can actually see in this curve, by 2 years, 71% of all the patients cross over to aortic valve replacement, either surgery or a TAVR, which essentially shows that even if the patient was asymptomatic, the aortic stenosis was clinically significant to virtually end up in any type of intervention at 5 months. So I think this is going to be a guideline-changing trial, and I think this important question in the field has been finally, answered. Another important question is, what about patients who are symptomatic, have reduced ejection fraction, but actually have moderate aortic stenosis? Can we preemptively treat these patients? And this study, unfortunately, that was done during COVID, this study was run by CRF, ended up with a small sample size, eventually because the difficulty of enrolling patients with moderate aortic stenosis and the difficulty of running a trial like this, but ended up with a small sample size that did not really give the statistical power that was required. Ended up with approximately 90 patients in the TAVR group and 90 patients in the conservative group. And the primary endpoint was the hierarchical occurrence of death, disabling stroke, hospitalizations, or change in KCCQ. As you can actually see here at the last follow-up, pretty much the longest follow-up that the patients were followed up, there was no significant differences in all cause of death, no significant differences in a stroke, and pretty much all the differences were related again on hospitalizations and KCCQ categories. Although the differences were significant between the TAVR and the conservative group, at the longest follow-up, this did not achieve significant statistical significance. At 1 year, the differences were significant for the TAVR group, and you can actually see that at 1 year, the differences are actually more robust, but the pre-specified endpoint was at the longest follow-up achieved by the patients. In reality, didn't achieve significant difference, but it shows a trend that early intervention in these patients could potentially be desirable to decrease symptoms and decrease hospitalizations in these particular patients. So we started to see a trend that is happening, worldwide, and this is U.S. data, in which in this database that is a U.S.-based Medicare claims-based data, approximately 12% of the patients undergoing TAVR in the United States are younger than 65 years of age. You see the number of TAVR procedures going up over time and the number of surgical procedures going down over time. At the present time, fortunately, these patients are patients with chronic kidney disease, with prior CABG, non-cuspid aortic valve disease, but in reality, it shows the trend and the appetite of actually going younger and going earlier because the ease of use and the simplicity of the procedure. But one of the things that I have to say at the present time is I think it's still too early to put Christmas decorations. We really need to be careful, as still we don't really have all the data that is needed. What do I mean by that? The present time, the intermediate risk trials and the low risk trials are expected to be released, the 10-year durability data between 2025 to 2028. So one of the first things is we have to be careful, we have to remain humble until we get the full data cohort for 10 years, so we start actually exposing equivalence claims. The other thing is when you go into a younger population, and this is the only trial that has presented 10-year data, you start to see the population demographics change. You start seeing more women, you're seeing smaller patients, you're seeing less calcific disease, and you see a higher incidence of bicuspid aortic valve. In this study, the NOTION trial, that is the only trial that has presented 10-year bioequivalence data, you see that, yes, the data looks great in this very small number of patients. No significant differences between TAVR and surgery. But what happens when you include the 30% of the patients that had bicuspid disease, you start see significant differences in outcomes between TAVR and surgery. So we have to be careful as the population is going to change as we get younger, and we're going to need more durability data. Another example of why we need to be careful, this is the SMART trial that randomized patients that were defined to have small annuli to do different valves. And even though clinically there were no differences between the valves, and this is the most important thing at the end, they did see important difference in hemodynamic behavior between the valves that could potentially affect clinical outcomes in the long term. So this is a word of caution. I honestly believe the data is going to come out okay when it comes down to the 10 years, but still, this is a data-driven field. We need to have the data in our hands before we just go and say, let's go crazy and expand the indication to a younger population. So the innovation focus in TAVR, I think, is changing, as we actually saw before. This is a complex anatomy, and you want to do it once, and you want to do it right. So the innovation focus is actually changing from all the design frame characteristics, treating tray leaflet lesions, to actually low-risk patients, more durability, more bicuspid, and actually higher hemodynamic, improvement. And I really think this is innovation in the TAVR, what is going. And this is an example, like the Siegel valve, which is a revolutionary low-profile TAVR system that is using a different metal. By different metal that is more resistant, they're going to be able to bring the device to a lower profile, getting actually a bigger orifice area, and at the end, potentially improving hemodynamics in smaller patients. This is like one of the innovation trends that is going on right now. The second one, which I really think is going to be a big game changer, is improving durability by targeting the leaflets. And we have at least 3 or 4 companies already working on innovative leaflet designs, innovative leaflet treatments, or fully polymeric leaflets that are going to decrease the potential for long-term anticoagulation and durability in these patients. Or the new wave of dedicated devices to treat specific anatomic abnormalities. This is the 2-year data presented, for the Trilogy TAVR, which is JenaValve, in which essentially showed in a single-arm study the durability, safety, and performance of a dedicated valve that can treat aortic insufficiency and is purposely designed to treat these patients' conditions. So we're going to start seeing these devices for specific anatomies, improvement in leaflet design, and improvement in frame design as well. And also we have, more disruptive technologies that, were presented. As you can see here, that I call this like a filler, in which in patients with aortic insufficiency, you can put a clip in one of the cusps, actually reduce aortic insufficiency, and why not delay the process of intervention for several years. So this is where the field is actually moving into more dedicated and more specific devices that can treat these device condition. What about mitral intervention? Mitral intervention is right now moving slower than we all want. But one of the things that is important to talk about mitral intervention is that mitral innovation is driven by the anatomical needs. It's very different than TAVR. And you see from one side technologies that are being designed to be very sensitive to specific anatomical features, and specific anatomical features are needed to be able for devices to work, to devices that claim to be more agnostic. And essentially, you don't care about the anatomy. You can reduce, MR by just obliterating MR, with a lot of actually flavors in between that are designed to treat very specific anatomical deficiencies in this condition. So one thing that is important and always say is, unlike TAVR, transcatheter mitral valve intervention will highly depend on the underlying anatomy, MR reduction rates, and most important, long-term safety, because every single approach has pros and cons when it comes down to thrombogenicity and bleeding risk as well. What about TEER? I am actually a believer of TEER. But TEER is actually a procedure that is standardizable because you can teach people how to do it the same way, but not necessarily reproducible. It's a procedure that is simple to perform with very high implantation rates, but it depends on the volume and experience of the center. You can get residual MR in some centers that ranges around 30 to 40%, and you actually have pretty much complete evolution of MR in single digits according to the center that you actually look at. The problem is the TEER performance in complex anatomy is a balancing act. In low volume centers, they get an excellent safety profile, but more residual MR. In high volume centers, they get an excellent efficacy profile at expense of mitral stenosis. So, this is actually a technology that it does a very good job, but again, is standardizable, but not necessarily reproducible. The future of TEER and other catheter-based therapy technologies depend on actually better imaging-based prediction model for technical success, device evolution to allow use in broader anatomical variations, and being able to reverse, the procedure like a clip removal techniques that right now are under development. In order to actually improve the outcomes in specific anatomies, we started to see technologies like this that essentially act like a leaflet extension devices to essentially decrease the deficiencies of posterior leaflet shortening. And we started to see new data with this type of devices with encouraging results. When we move into the full replacement field, which is extremely exciting, but moving slower than we all want, the biggest advantage is actually easy to implant, is agnostic to the etiology because it works on primary and secondary, is very reliable in the elimination of MR, and less recurrence of MR than in actually other technologies. But the question is, why this is so great and is moving so slow? You can actually see one of the examples on a technology that we were very involved with, where you see the ease of use, it looks like TAVR, is a highly controlled technology, and pretty much you end up with a zero MR at the end of the procedure. But the question is, why is the field moving so slowly? Well, the reality is, at the very beginning, we and others came up with a lot of designs, a lot of ideas to adapt to the mitral anatomy. But pretty much the reality is, of the real world, is there are a lot of anatomical variations in these patients, and pretty much not a single size fits all. The good news is we already know, why patients are getting excluded. A third are related to clinical reasons, mainly futility, patients that are very advanced, and really the technology is not going to help them. 2/3 are related to screen failures, related to the risk of LVOT obstruction, severe MAC, small annular area, and septal height. But the good news is these devices are evolving very quickly, and a lot of devices already adapted to anatomical needs, and they promise to be able to fulfill the needs. And ideally, as actually I put on this hypothetical projected chart, we're going to have a device available to use clinically by 2028, because clinical trials with all these technologies right now are undergoing. Finally, what about tricuspid? Tricuspid is the hottest topic right now in interventional innovation. We right now face both edges of the spectrum. From one side, a device that abolishes completely TR and is actually have some safety considerations related to the procedure. On the other side, we have a technology that is super safe, more complex to use, but doesn't completely reduce TR. At the present time, there is a favoritism on replacement because essentially multiple anatomical abnormalities is limiting the TEER success. We have a whole bunch of options on the replacement side of things, and actually also because it's easier of use, is friendlier on imaging requirements, and the technical results are satisfying. We have big news. This big clinical trial was presented at TCT that is called the Trident study. The final results, the randomized 2-to-1 patients with asymptomatic TR, severe TR, to TTVR or medical surveillance. And you can actually see the final results, complete abolition of TR in most of the patients, obviously compared to the control group, and a significant decrease in the composite endpoint, but primarily driven by KCCQ improvement and functional status improvement, no significant impact on mortality or tricuspid valve intervention. But there is an upfront cost for the total TL resolution, as you can actually see here, higher cardiovascular mortality, severe bleeding, and more pacemaker implantations, that these are actually the features that we all believe can be improved with the next generation devices that are not purposely designed for the tricuspid valve and actually friendlier when it comes down to pacemaker rates and actually bleeding, as you can see in this technology where the pacemaker rates got extremely reduced and bleeding complications were pretty much not really seen. The tricuspid field is moving forward in a very aggressive way with a lot of technologies on the repair and replacement space that promise to really improve these outcomes. And I really believe this is a field that is already clinically available and will continue to grow very fast over the next several years. So there's never been a better time to be a structural cardiologist. It's an amazing field that is growing up very, very quickly. But you know, we have to be very careful because these are actually procedures that are forcing the operator to go into a very specialized areas in low volume actually centers. So we need ease of use, we need less procedural needs, we need technology that are simpler and faster to be used. We have a patient that more and more is becoming a consumer, wants faster recovery, better quality of life, and obviously we need to make sure that from the financial point of view, things work for everybody, which is the biggest challenge we have right now. But one of my biggest concerns, just to finish this talk, is that we're introducing all these techniques and essentially to train better our operators. We're forcing people to interpret complex 3D anatomical abnormalities, navigate catheters in unknown anatomical spaces, and adopt techniques that actually are not really learned in interventional training. And that's why training education also have to evolve, and we need to train people in a different way so they adapt and learn all these techniques. That's why meetings like this forum are extremely important to keep educating the physicians, and that's the reason why we keep investing our time and efforts in these educational activities. And we welcome everybody again to TCT Middle East in April next year for an amazing opportunity to interact and continue working together. So again, thank you very much for the kind invitation. Thank you for your friendship, your candor, your kindness, and hope to see you again soon and keep collaborating in the future in these and multiple other programs.